Very good afternoon, one and all of you. May I ask my co-instructors to join me here? Dr. Abhay Savda, Dr. Chitra, Dr. Partha Vishwas, Dr. Tityal, and Dr. Maipal Sasdev. I think a couple of them would be joining us soon. This is going to be an extremely practically oriented IC on cataract surgery. And each of these speakers are stalwarts in their own right, and they're going to be, I've requested them to specifically give tips tips on what they do practically every day in their OR, managing simple situations. We are not going to handle complex cataracts or difficult scenarios, but what you can hear today and employ tomorrow. And to open the session, I can't think of anyone better than Dr. Abhay Savda, who practically requires no introduction anywhere in the world. Doyen of cataract surgery in India, and I've learnt and continue to keep learning from him constantly every time I meet him. The way we have formatted this session is that the presentations would be for 7 or 8 minutes. It's left to the speakers either to deal with one topic or just give 2 or 3 practical tips, and then we'll have a panel discussion on what exactly they presented. And questions and audience participation is most welcome.
Okay. Good afternoon, and appreciate your presence in the late afternoon sessions of lovely city Kolkata. And I'm going to speak very basic, so if you are still in a postprandial stuff, remain there. It's nothing very new or exciting that I'm going to talk to you. This has no relevance, but this has happened more than once to me, and this is what I mean. Everything is going well, and sometimes I don't focus well, my concentration is left, so sometimes even in spite of everything this happens, and the fact is it does happen. So it's very embarrassing, and then obviously the trick is to use the endocapsular ring, and that's not a big deal, but I realized having lost one ring, so I now learned, and particularly in my team, if anybody's putting ring, I ask them to put a 10 or nylon threaded into the eyelet, so that at the end he will remove that and cut it. But in case if he has to sort of bring back from the well from behind, it's easy to retrieve this kind of endocapsular ring. So that's okay. But we were worried, we were embarrassed. Why did this happen? So we went back and we are reviewing our video of that same patient. What happened? Why did he get this zonulolysis? So we are reviewing our video, and suddenly the hydrodissection came, and the surgeon is just pushing it very gently on the surface and trying to remove, and see that? This was initiated because you were just swiping on the surface with the spatula from the side. So that's something make us think. So how does this spatula make this lens rotate? Well, it's not a rocket science. We know it for years, and I've learned from the faculty sitting here. You need to press, you need to go to the side, preferably 90 degrees, as away from the central axis than you can, at least 3 clock hours. Press downwards. Why? Because you want to use the posterior capsule and zonular support as a tempoline to support it on that posterior layer, and then rotate. And it will rotate if your hydrodissection really was subcapsular or corticocleaving. And this is what happens. If you really press and go 90 degrees, it will rotate very easily. So that's one thing. we learned? Well, whatever you do, it doesn't rotate. The fact is, many times it doesn't rotate. The next step would be to rehydro it. Do not make it a stressful rotation. Don't do this. So to come out, no ego, it will take time. Inject dispersive viscoelastic a little bit, and then rehydro it in the area you're comfortable ergonomically. And I use and recommend this curved cannula, which is a copy of Dr. Akahoshi's cannula, and direct it toward the fornix. The standard teaching is that you tent the anterior capsule and lift up. It is okay logically, but it doesn't work many times. So if you instead introduce 1 mm at least beyond the anterior capsular rexus and direct it and follow the curve of the lens. The curve of the lens is like this. Little down, not up, as I used to do. And it will invariably follow the slope and will produce a rotation. So that is something that I've learned over the years, and I try it. You may like it. So sometimes there are conditions called corticocapsular adhesions, and these are the adhesions. They are actually a kind of a cortical cataracts, and therefore occurs in a mature and cortical cataract. It doesn't occur in nuclear sclerosis, of course. And these superficial cortical cataracts are attached or adherent to the subsurface of the anterior capsule. And why they're important? Because they will resist the rotation, and if you do not make this egress of the water through that, you will have a problem. And also, if you try to suck it out before separating out, you produce what I did in the first case. So these are equatorial CCAs, and they are not seen. So if there is a resistance to the fluid waste transfusing, think about it and anticipate it preferably. And we found that it's useful in all kinds of cataract. In 2003, we did that with Dr. Apple and Jagat Ram and Liliana, the American Journal, that the multi-quadrant hydrodissection is a good idea for various reasons, including PCO retardation, but here mechanical impact. So look for CCAs, avoid stressful rotation, proper understanding how you use these posterior capsules to support the nucleus, and then rotate. Okay. Now, what I do now is not whatever I showed. What I do now is I'm going to show now. What I do now is I produce a good hydrodissection way, and if I'm satisfied, I do not attempt rotation, which was my rut, which was a default step. After hydro, I rotate. I don't do that. What I do now, and I want to produce a crack, whether I do sculpting or I do direct chop without any space, it doesn't matter, but I will rotate this lens only and only once I actually produce a crack. So this is a good way. I'm satisfied. So I'm doing a little trench, but I could have done direct, doesn't matter. The idea is to really produce a division, and mind you, the hydrodissection is good, so I'm not worried. And now what I'm doing is I'm using the principles of fulcrum and the long arm and the short arm. I will introduce the vertical element of the chopper as peripheral in the crack, in the groove as I can. And this is the center portion here. So we have a long arm here. The chopper will exert the force like this. So long arm, and you can understand if I try to do it here with the short arm, I have to use more force. But if I do it over there, my force required is very minimal to direct the lens moving in this direction. So minimal force required for rotation. And I don't have to use this support of the posterior capsule and so on. So I recommend that if you're satisfied with your good wave, you know for sure you've separated it. Don't worry about it. Produce some kind of a space to introduce the chopper as peripheral as you can, and just with a little thing, it will rotate. So I find that very useful. It's gone? Or what's the time? It's over? 10 minutes? No. 7 minutes. So now this is a different thing altogether, and you can stop me, please, if you want. Now, notice that I'm doing this, whatever parameters, low parameters I use, but that's not an issue here. I'm doing that here. And this sub-incisional, what happened, and I think Rohit Om Prakash has also probably alluded to some of these things, but it's so common, isn't it, that these small fragments come and sit on the side port through which you introduce chopper. So what I do, and it's so frustrating, and it will never come. You touch the endothelium and so on, and finally you manage that sort of thing. You have to manipulate and things like that. So I'm really tired of this over the years. So what I do now, and I'm doing it for quite a while now, that if I come to a last fragment, I need this chopper to manipulate. So I want to have it, but not until the end. So as I come to a last 1 or 2 fragment, I will remove the chopper now. You will see me removing the chopper. And then I'm so easy. Why I'm doing it? Because there is no competing currents of water exiting through the side port. Because chopper is never stagnantly fitting. So I removed that competing current by just removing it. And every time, I never leave behind subincisional fragments. Sometimes it goes behind the iris, and we detect it later on. So this is the second tip that I wanted to share with you. And these are some other examples. I think with the time, I'll leave it. But remember, this is what I wanted to tell you. There is a competing current making these little fragments here underneath the side port. And aspiration flow rate is not that strong. Even if it is 30 or 35, it won't be strong. So instead, I found, and I'm so happy now, no embarrassment, and it eventually comes because I removed that exiting competing current. So thank you so very much.
Great tips, Dr. Abhay. Just a couple of questions. That endocapsular ring that you used, I saw there was quite a gap between the 2 eyelets. And I used to use that earlier. Rather, that was given to me. I used to use it. Sometimes once I place it, I used to find there is a large gap in adequate support. Nowadays, I use usually a 13 or a 13.5 millimeter with both the eyelets almost abetting each other, so that you get a all-round 360-degree support of the capsular bag.
I think it's a wonderful, and folks, if you are really listening to it, please order what you are using, and I will order it straight away. I never paid attention to that gap. So thank you for enlightening me on this issue, because I never thought but I agree, there was a huge gap. Thank you.
And other question is, all of us have been talking about conventional horizontal chopping, vertical chopping. Horizontal, ideally we used to go right up to the equator and then chop vertical just in front of the phaco tip. But I think most of us are doing what we are doing now is hybrid chopping, something that I also saw you doing, where it's not very close, but essentially the movement is something like a horizontal chopping, but you move it towards the tip and then separate.
Yeah, I think the key is that from physics point of view, further you go away for chopping, put your chopper, say, around the equator, and do it, you will have to have a less force. But the reality is that how many times you can really go there comfortably, ergonomically. Even if you've done first crack, as you produce second, third, you find difficult to twist your hand and introduce the chopper under the rexis and so on. So you give up and you come closer away from the periphery. If you come away from the periphery, you need to combine a little bit of a vertical chop in situ, as I call it, vertical movement, and a little lateral rotation. But be safe, whatever. But from purely physics, further you go better. That's why the Nagahara was right in that. But in reality, we are not able to do it in every patient and not in every circumferential 360 degree. We give up finally after 2, 3, 4, and we switch on to this kind of hybrid or whatever you call it. So that is a wonderful thing. Thank you for bringing it up.
And lastly, I was intrigued by the fact when you said that you do hydrodissect but don't rotate your nucleus. Yes. I always do that because I think that breaks up the corticocapsular adhesions.
Yes.
And I don't proceed with introducing my phaco tip unless I have a free movement of the nucleus.
Yeah, actually, I agree what your concern. I can see your concern. What I mean is that I want to rotate, surely, before I rotate the nucleus. So do not rotate the nucleus before you actually do the rotation. So I do a space first where I don't rotate. The nucleus is still in situ. hydrodissection is done, separated, and then I use this principle of less stress and rotate. But you have to rotate before you start rotating the nucleus for chopping or whatever technique you have. So I do rotate, and I believe rotation is mandatory. But I just push that back little. But if you push it back, make sure you don't rotate the nucleus. The nucleus has to be there. If you cannot produce a crack, don't do this. Thank you.
Thank you so much. Please join us in the panel. And now it's my pleasure to ask Chitra to take over and present her pearls.
Thank you very much, Dr. Ramamurthy, for this wonderful opportunity to present in this august audience. And my tips are something which maybe all of us could connect it, very simple and very much day-to-day pearls. Like, how are you going to hit target emmetropia? Now, all of us are wanting every surgery of ours to be hitting target emmetropia. And for this, I have given the choice of using the Barrett's suit with all the formulas. That it's essentially a thick lens formula, and it takes care of the regular universal or the toric, or it is used for refractive surgery or combines in refractive with toric, or as a enhancement procedure. But whether it's Barrett or anything, it has to be a 4th generation formula where it's not only axial length and K value, but also anterior chamber depth and many more details which are coming in. Before we take any patient when he comes for counseling, first thing we do is put them onto the Barrett toric calculator and find out whether the person has some amount of cylinder or astigmatism. And if there is, then we take our direction and tell him that you could consider a monofocal, but since you have an astigmatism and you want total independence for distant vision and a hit emmetropia, then why don't you go for a toric calculator? Now, why am I insisting on astigmatism correction is, even more than 0.5 diopter astigmatism, the image quality declines if it is not corrected. So if you want that precision in image for your patients, you need to take care of that. And it becomes even more important in premium multifocal IOL that even if the astigmatism is just 0.75 diopters, it has to be corrected. And how you would go about it, now again, if it is against the rule astigmatism, even 0.75 could be treated with a toric IOL. The other important thing for hitting emmetropia is getting a good K value, because there are a lot of variations in the gadgets and also the ocular surface. In fact, if you look at this slide, the patient had 0.5 diopter astigmatism in the right eye and +2 in the other eye on doing a keratometry. But when we saw him on the slit lamp, there was so much of pigment epithelial erosion and dry eye signs. So after treating the dry eye, when we remeasured the astigmatism, it was only 0.2 in both eyes. So if we had not clinched this dry eye issue about that patient, our biometry, keratometry, everything would be bizarre, and where would be hit emmetropia? Again, in this patient, he has a +1 diopter in 1.6 in the right eye and 0.3 in the other eye. If you look carefully at the Myers, it has a fishtail appearance, and there is some artifact there. So all of this would again has to guide you. There's something wrong in the ocular surface, treat the ocular surface, and then the astigmatism is reduced. So then, we also know that optical biometry is top-notch for axial length measurement. But again, immersion is great. But there's nothing wrong about immersion. But when you're doing immersion, this patient has 22.4 axial length in the right eye and 21 in the left eye. Why is it smaller in the left eye? But then if you look carefully, you realize this particular patient incidentally had a macular tractional detachment with subhyaloid hemorrhage, which is why he had a false short axial length. And if you had not checked on this, you would have put a +7 diopter, a different IOE part in that eye. So then, again, what is it finally for hitting emmetropia? Treat the cylinder. Use the 4th generation formula or better. Please measure both eyes. If the axial length difference between the two eyes is more than 0.3, repeat your measurements. If the K value between two eyes is more than 1 diopter, repeat measurements. The IOL power difference between the two eyes is more than 1 diopter, repeat measurements. In fact, cataract. You should measure both eyes. Even if the other eye patient comes with a pseudophakia in one eye, please measure that eye, because variations in the axial length and the anterior chamber depth K value will tell you whether the eye which you're going to operate, whether those measurements are correlating or are you on the right track. So we go on to my tip 2. What would be your choice of IOL after laser vision correction? Is there a role for diffractive IOL? Now that's a very pertinent question for post-LASIK patients. Now this was a spotlight study in AAO which looked at a patient who had a good topography. What was the popular demand of the audience? There were 55% who wanted monofocal mini monovision, and 27% wanted EDOF, and 9% wanted multifocal. Now, let's be logical. If the patient has, during LASIK in his late 30s or early 40s, comes to you for laser correction, you could do a mini monovision, monofocal mini monovision, and he will be very happy for that in his premium cataract surgery also. If he's a high myope, it doesn't make sense to put a multifocal. You could do a monofocal, or you could put an EDOF IOL, because his contrast sensitivity is already hit by the high myopic ablation on the cornea. If it is a hyperope patient, you could put an EDOF, you could put a monofocal, but you could also put a multifocal if it is not a very high hyperope, because the central cornea is not very much affected in a hyperopic ablation. So we also know that all these lenses of aspheric, enhanced monofocal, EDOF, everything does very well in an emmetropic eye. But how do they do in a post-LASIK eye? And what would be the IOL formula which you would use? For that, again, there was this spotlight on asking audience questions, and it was found that many people felt that the ASCRS calculator was, the Barrett's-Truquet was the best, followed by ASCRS. So, and then came Haigh-Giesel. So this is how each person had experienced. So we tried this on our patient here, and if you look carefully, maybe the lettering is small, but what in this came true was the patient needed toric in both eyes, but he did equally well with the Haigh-Giesel measurement and the Barrett-Truquet measurement. The important consideration for a multifocal IOL patient is when your patient says he's had LASIK, but he tells you that he was very happy with the quality of vision he gained after refractive surgery. If you see his ablation is well centered with no irregular astigmatism, if he tells you he had no night vision problem, you see he has a good ocular surface and is a highly motivated patient, go for multifocal IOL in a post-LASIK patient. Look at the topography. Look whether it was a myopic ablation or a hyperopic ablation. Look at that 3 millimeters. Is it a decentered ablation? Then no multifocal. Is it a residual astigmatism? Is it irregular? Look at the ablation pattern. Look at the ocular surface. Look at the eye trace, whether the corneal aberrations are more or the internal aberrations are more. And is there irregular astigmatism? If two IOL master and lens star are differing, if the difference in astigmatic meridian between the two biometers are off, then go back and repeat your measurements. And then, if you're using Barrett-Truquet, you may not have the best of keratometers, you can still use the predicted K value of the Barrett or the measured K values. You can go into that particular format and you could calculate what is going to be the astigmatism. You could do it on the laser cataract platform or the best surgery possible, and this patient will do very well. But you need to tell this patient that you may have a residual, you may need enhancement. The last tip is a small tip. This is phaco following lens touch. Now this kind of cataract which you see immediately or shortly after surgery is seen more in a gas tamponade. So you need to be very careful about doing hydro in these eyes. The rapid progression of cataract does not happen. It takes 6 months to 1 year, 1.5 years, unless there has been a lens touch. If you do a uveum, you will see the posterior capsular dehiscence and a little lens matter. You will see little loss of compactness of the nucleus. And then you also, what you should do is, if you feel there's lens touch, wait for a period of 6 weeks, let that area of opening fibrose, and then you could go ahead and do the surgery. And the last bit, when you do surgery after 4 to 6 weeks, expect a deep anterior chamber. Remember, there's no vitreous support, and you have to keep your parameters low. You need a structured wound. You need to keep in mind there could be a retrolenticular block. So you need to be conscious of all of it. And sometimes you could even have a PC plaque, and you need to be able to peel it and take it out. However, this case was very uneventful and it got done. I have one more pearl. Should I leave it? Huh?
We can stop here. I think very pertinent points that were made, and perhaps to me the most important factor is the formula that we use for biometry. We swear by the Barrett suite of formula for all situations, and our go-to formula is not Barrett Universal 2 but Barrett Toric Calculator. Because I'm often asked, what's your limit as far as introducing toric lenses is concerned, whether it's 0.6, 0.7, 1, etc. Please remember, against the rule astigmatism and with the rule astigmatism have completely different connotations. So we put all these patients on Barrett Toric Calculator and let the formula tell us whether the patient needs a toric monofocal, toric lens. Then subsequently, the counseling happens as to whether it has to be toric, monofocal, multifocal, etc. So rather than just going by the magnitude of the astigmatism, take on also the amount of the axis of the astigmatism which is incorporated in the formula. As regards usage of premium lenses in a post-refractive surgery scenario, I would like the three of you to comment just briefly.
Yeah, I think regarding the post-refractive, she's covered it pretty well. I have only one thing to add. If a person has had a Pressbeyond done, then you don't need to do any of these things because the cornea stands, it still has the abrasion profile, etc. that has been done. So if you have had a Pressbeyond, then the cataract surgery you would want to do a typical just a monofocal or maybe a monofocal plus. You won't want to look at EDOFs, or you don't have to look at multifocals. But for me, a preference would be to give a mini monovision post LASIK. The lens power calculations are pretty accurate that you have on the Hagizel and the Barrett, and that you get on the IOL Master 700 now. I think almost all the new Lenstar also has the post LASIK, and the Interion also has it. So that's almost a standard of care. The problem that typically comes is to get a good power post RK. Because that whatever you may do, it's a slight problem. I do put torics in post RK, but you have to do a TrueNet K and then work on that. So that's all that I will wish to say on refractive surgery.
Partha?
Yes, so just to add about the refractive surgery part, so I, for the last nearly 15 years, I've been following the best of calculations, and here of course the Barrett is the best that we calculate, but the last thing that we do is a cross-check with our senior most optometrist to do a phakic retinoscopy on the table, so that to avoid any surprises, and it has worked very, very well. We always try to keep post-LASIK myopia, somebody who has got LASIK for myopia, a little on the, to err a little on the myopic side, and till date, no surprises after doing this.
I think you're the only one I know of with a large volume who does this. What is the multiplication factor that you apply for the refraction?
Approximately 0.8.
0.8. Okay. Yes, Dr. Abhay?
No, I just wanted to say some of these things that you've been told, but post-RK, I think the regularity of astigmatism is very important. So many of these with little astigmatism, make sure it's regular. Do not put it in irregular. And we use all these eyes, post-treated corneas or otherwise, Barrett True K, because as you very correctly emphasize, you'll be surprised, because if it is with the rule or against the rule, and there the formula will show this is T2, it's half a diopter of thing, and that's worth doing it, particularly if you're doing a multifocal, trifocal lenses and so on. So that you must test whether does it need toric with the formula, not by your assessment or judgment.
Also in a RK, if the optic zone is very small and there are too many incisions on the cornea, there is irregular astigmatism, and these patients will do good with maybe enhanced monofocal or maybe a EDOF if the irregularity is not much.
No,
but definitely not a multifocal.
More than concern for multifocals or enhanced monofocal is whether to put a toric lens in or not. If the patient was having good visual correction with glasses, did not need a semi-soft or a rose scale lens for the refractive correction, then he or she is a good candidate for a toric intraocular lens also. But if it was mainly higher order aberrations, irregular cornea where he or she required a rose scale lens or a miniscleral lens for visual rehabilitation, then obviously a toric ICL or a toric intraocular lens is not a good idea. Let's pass on to my topic. I'm going to be just dwelling upon certain tips that I routinely practice for hard cataract. And I know several stalwarts are here. And one of the things is a good dilatation is paramount, otherwise use some kind of pupil expansion device. Get an adequate rhexis. Usually it's extremely important that 5.5 to 6 millimeter rhexis. If it's constrained, then the entire thing becomes a little bit of a problem. As already emphasized, a good hydrodissection and then making sure there's free rotation. And this is actually dispersive viscoelastic that's going in to coat the endothelium. And then I put a little bit of HPMC. This slide is running at 2x speed. And then I make a small trench. And at the depth of the nucleus, I go ahead and bury my phaco tip with an adequate exposure of the phaco tip and do my initial chop. It has to be, you have to make sure, multi-level chopping, as Dr. Vasavada has often emphasized, you need to practice that to make sure that the initial chop that you make is going through and through, and you get a red reflex through. And the number of chops that I create is directly proportional to the hardness of the cataract. Usually I stick to 4 chops, but then in a harder cataract like this, it may be 6 to 8 chops. It's more important that each and every one of them is completely divided, and there is no central core area where there is an addition of the nucleus, and these all should be independent. So all this has happened within the confines of the capsular bag, and I usually use only longitudinal phaco for this. Subsequently, once again dispersive plus HPMC, and now I switched over to only torsional phaco. And as you can see, I keep my phaco needle bent towards the capsular bag, and then subsequently I don't hesitate to refill with viscoelastic as many times as it is needed. My dictum is usually about every 5 seconds of CD I go ahead and refill, especially these hard cataracts. And then you have to always be cognizant of these flying fragments going ahead and hitting the back of the cornea, and that's the nucleus that has come out. You have to be aware that very often these hard cataracts are also have concomitant capsular bag which is unstable, and that is hydroimplantation of the intraocular lens. It's I think a multifocal lens that goes in and works quite well. But I am aware that many of us, I think this is also again a hard cataract, and removal of the whatever cortical material is there. Usually I stick to an intraocular pressure of 30, though the earlier this video was showing something higher. And mind you, at this phase I use only longitudinal phaco, no torsional phaco at this phase. And that's create a small trench, get a hold on the core of the nucleus, then subsequently create that separation. That lateral separation that you do should not be too strenuous, because that itself can put a considerable strain on the capsular bag. And as we discussed earlier, basically some kind of a hybrid between horizontal and torsional, horizontal and vertical chop. I bury at the edge of the capsular rhexis and move my chopper towards the area where I've implanted the phaco tip, and at the same time there is a certain amount of lateral separation that takes place. As and when once for the sub-chopping, sometimes you can bring the nucleus out and then go to the right to the periphery and then do it. As you can see, that entire, it's essentially slow, deliberate movements. The earlier video was running at twice the speed, but this is the actual way I do it, and it has to be done in a very methodical manner. And unless the nucleus is freely rotating, I don't even go ahead and start my phaco chop. And you can see that the amount of energy used within the bag is extremely low, and it's only during the quadrant evacuation that you end up using most of the energy. And intraocular pressure of 30, which translates to a bottle height of about 41, is quite good enough. My settings are not too high, but vacuum is around 600, aspiration is about 32, 34. That gives me good control. And then I refill with dispersive viscoelastic, and then a central bit of HPMC, because the dispersive viscoelastic per se could be thermogenic. And then this is, I just keep the phaco tip centrally placed and allow the fragments to flow into the phaco tip, and it's essentially the fluidics that brings it there, and do the entire maneuver as posteriorly as possible, though I believe that it's not really endocapsular phaco, but it's happening, most of it is happening in the anterior chamber in a posterior plane. Subsequently remove the cortex quite completely. Always be aware of the fact that the haptics might be a little loose. Introduce the intraocular lens, remove the whatever viscoelastic is there left behind, and then stabilize the lens. I know not all of us are completely comfortable with doing a phaco chop in very hard cataracts. I think stop and chop is a great way of dealing with these cataracts. Even now, once I've created the central trench, and if I feel that I am not getting a complete chop, adequate chop, I have no hesitation in going ahead and extending that to and converting to a stop and chop. So here the idea is to create a deep central trench of about 1.5 to 2 times the width of your phaco tip. And as you can see over here, it's down up sculpting, and then you can see that I want to thin out the posterior plate as much as possible. Whether it's direct chop or whether it's stop and chop, the idea is to break the backbone of the nucleus. I go in with 2 Sinskey hooks through the 2 side ports, go into the depth of the central crater that I have created, and gently separate them. And if I feel that I have to exert undue pressure, I don't mind going back in again with the phaco probe and thinning out thinning out the plate. It's extremely important that when you are separating this, it has to be 2 complete heminucleus that is made, and at the same time you do not do too extensive lateral separation to stress the capsular bag. And once this is done, you can bring out each of the heminucleus into the anterior chamber, doing as the entire procedure as posteriorly as possible. As you can see, most of the energy is consumed during this phase. That is the reason that it's a good idea to use a refill with the viscoelastic, dispersive viscoelastic, especially to coat the endothelium. So what are my dozen pearls for dealing with a hard cataract? Choice of anesthesia: do not hesitate to give a peribulbar anesthesia because the surgery might be long. Make secure long incisions which are not leaky, not only the main port but also the side ports. 5.55 millimeters well-centered rhexis, hydrodissection and rotation so that you break up all corticocapsular adhesions. If you're doing a direct chop, make a mini trench and then bury in your phaco tip. That gives you access to the meat of the nucleus. If it's a stop and chop, then make a deep trench and introduce your Sinskey hooks into the right in the center. As far as the chopping is concerned, I use purely longitudinal phaco during the chopping, and for quadrant removal I use torsional phaco. If I use torsional for chopping, I feel that that sort of enlarges, reduces my hold on the nucleus bit. Break the backbone of the nucleus, multi-level chopping, gentle lateral separation, posterior plane phaco, especially during quadrant removal. Use adequate amount of dispersive viscoelastic, but please remember it's thermogenic. So I always have a small lake of HPMC in the center where my real phacoemulsification happens. Just in case you are not doing it, always evacuate a little bit of dispersive viscoelastic before activating your phaco. And beware of the weak zonules and capsule all the time, and take care. Thank you so much. Comments?
I think you covered it so well, each and every details. But for coming back to the hydrodissection, on one hand, these are the cataracts which may have a corticocapsular adhesions and it's been stretching the capsule, and you want to make sure that there is no stress to the thinned out capsule. So we want to do hydrodissection, sure. But on the other hand, because there is no space, it's not easy to perform hydrodissection, and you are in trouble actually sometimes. And you think you might overdo it, and that procedure itself might produce some problems. So what I do is that I try one time in whatever expertise and whatever experience I have, or anybody who has done, and do it a little gentle hydro. If it doesn't work, maybe you may try again second at some other time, but don't make an issue of hydrodissection and rotation with these kind of cataract that you showed. I'm glad I'm not in Coimbatore. So do that, and as I say, do some sculpting. Again, try to do hydro, not rotate before you make sure that you have a good hydrodissection. But hydrodissection is mandatory, but it can be lethal also in these kind of cataracts. So be careful. Use your judgments.
I think very well covered. The only thing, as he has emphasized, is to have two hemisections, and often there are two things that we fall for. One is, as we try to. It's easier to trench in the periphery than in the center, but the center has the thickest portion of the nucleus. So you should always break the backbone. The periphery will always follow. So if you break the center, the periphery will always follow. So don't try to start the crack from the periphery and try to come into the center. So that is not going to be helpful. And the second thing that is there is that in case you have not been able to transact the fibers at the backbone going past the midline, then rotate 180 degrees and then go on the opposite side so that you can actually break it, rather than doing a 90-degree rotation and then trying to do that. I think there's a question there, yeah.
So, sir, in the case which you showed, a couple of times I burnt my hands when I couldn't see my posterior pole, did a hydro and did a good hydro so that I could, and the cataract just sunk. So what is the way to, these are, one can always see the other eye if, there is any evidence or any of posterior polar, but sometimes if a posterior polar is hidden behind a brown cataract, then how do you...
No, normally when you, after doing each hydro, I would decompress and then do another hydro. So you need you can't keep on doing multiple hydros. You need to decompress the back so that you want to have the fluid wave have moved across.
No, that's not the problem. The problem is that you can't identify a posterior polar. That's what you're saying.
Not with an overload.
So basically, the first thing is the other eye always tells the story. You have to be very careful and ask that. The second thing is imaging devices. You should use an imaging device. A good UBM, as she showed, can do that. Even a OCT and Anterion will give you that. Even an IOL Master 700 can give you the integrity of the posterior polar. And if you are doing a femto, that also will give you the integrity of the posterior pole. So these are very underutilized by us, the OCT devices and the IOL Master 700. You can, I have good images. If I had the time, I would show you, but I have good images to even show the IOL Master 700 can give you the integrity of the posterior pole. So that is the only thing that is there. Apart from that, yes, it does happen. You do the fastest phaco surgery for a patient. You just do it at the...
But I think ASOCT is a must for all posterior polar cataracts today.
He's saying that. No, maybe for hard cataracts also.
I think Mahipal has nailed it. He's absolutely correct, and you must remember what he said. In our place also, if you cannot assess a dense brown or a black cataract
assume that it
capsule, we do both B-scan for retina and also for the UBM. We have both. But if you don't have these modern machines and flex and all that, so in other words, do not operate on the table, do not take him on table unless you are very certain so that you can plan your strategies. So it's very important.
Any brief comment, Partha, on hard cataract before you start?
Yeah, just a very brief comment, sir. It is at times with these rock hard cataracts that the fibers of the posterior pole have not separated. So then lifting a pie with a fiber stuck can become quite difficult, but under good molecular weight viscoelastic, the pie can be lifted, and severing the fibers manually by a sharp chopper can do do a great deal of importance and save a lot of phaco energy. So if those final fibers of the posterior pole can be severed with the pike getting lifted up, and that's quite atraumatic, and manually, and then the phaco emulsification can take place.
Can I make a comment here? Sometimes, Partha, these hard cataracts, we keep chopping, but central area doesn't get, divided. So sometimes what I do with the peripheral chops, you're eating something, so slowly, lift the central area, and if you hit the central area, all the, it's like a flower pattern opening.
Yeah.
Then you can do, if you are worried, you can put a viscoelastic underneath that.
Underneath.
And break the central area with your phaco.
Right, sir.
I think now it's over to Dr. Partha. Needs no introduction. We are in a city, and
Thank you so much, sir, and welcome to the City of Joy once again, and come back again and again. So I just thought of showing a few pearls which are very, very basic things. One is a basic amount of the fibers which are attached to the posterior capsule, and in today's world when we use very high-end microscopes, these microscopes show you much too much than you possibly require, and that is the dilemma that we have. And after doing a good cortical cleanup and everything, you find fibers which are still sticking to the posterior capsule. So how do we remove them without endangering the integrity of the posterior capsule? And that's what I'm going to show in this video. It's been fast forwarded a little, but and I'm not able to pause it because of this. So a very, very fine cortical wash, and thoda kam kar. And so once this wash is done, what you will see is those fine fibers that are still sticking at times. So if they are sticking and you want to remove those fine fibers, what is required is you put in methyl cellulose, viscoelastic, fill it up, and then very gently aspirate the fibers with a marriage of both the irrigation and the aspiration tip very close to each other. So the manual separation of the jet of fluid that comes out from the irrigation tip actually holds back, and in the presence of good viscoelastic, it holds back the posterior capsule, and you can gradually take off these thin fibrils. At times, the fibrils are sticking there. There can be a small plaque. You have to be aware of that plaque. It is possibly an area of weakness. So at these times, what is possible, what you can do is place in the intraocular lens, and then with the irrigation over the intraocular lens and the aspiration behind, you can very gently take it out. At times, you can just go in with the irrigation behind the intraocular lens and rub on the posterior capsule with the jet falling on it. So these are small tricks, very, very basic. Most of us do it. I'm sure some of you do it right away. But these are things that we can definitely do without endangering the integrity of the posterior capsule. So the next pearl video that I'm going to share with you is something of a little different magnitude, and it is about opening the ports of a flax. Now this has been something, I'll just take a show of hands from our panel who are all doing flax. How many of you, sir, open the side ports or create a side port to open that up in flax? Only the main port, sir? Only the main port. Okay, so we just found out a few ways, a small trick here or there, to open up even the side ports. What actually happens, the side ports are small, and maneuvering the side ports to open up in flax can become a little difficult. So opening up the ports. Now the first thing is the curvature of the spatula has to be such that in conformity with the the plane of the port. So that's very, very important. At times, the superior port might be difficult, especially if there is a possibility of arcus senilis, which is very dense. And the side ports actually can be done very well. Now this is the main port that can be opened up in most of the cases. Here you see a blob of hemorrhage over there and conjunctival hooding, which makes the port opening difficult. And here you don't need to struggle, you can just put in the side port and do it. If it is a redocking case, in this patient redocking was done, so it was difficult to open the side port, and the struggle should not be such that you make a false passage, because that might scarify and that would remain a scar. Most of the times the wound, the main port opens very well. Now the viscoinflation of the anterior chamber is very important, and with the viscoinflation, so this is quite important, and there should be possibility that the LRIs are not actually opening onto the ports. So if an LRI is there, so you need to make incision with a blade which is beyond. Now just let us look at this part of the video. Some scenarios can really think difficultly, but it can be opened with a spatula. So you can see that there is chemosis over there in the superior port where we are trying to open it. But if you put in viscoelastic, and if you have the globe well formed, the anterior chamber well formed, and if you can gauge that which is the plane in which it will go in, because the plane, if you have been able to identify, the spatula will go in quite smoothly. If there is struggle, if there is a lot of pressure, it will not go in, and that means you are not in the right plane. So look at this patient with a lot of a dense arcus. Here even there is vascularization. But it is possible, again, with the right technique and with the right amount of pressure in the anterior chamber. You need to fill and refill at times the viscoelastic, and it will definitely go in very well. So these are a few of the pearls that, so the angle of spatula should conform to the incision. No force. If you make a very lot of force, it will create a false passage. And the AC should be optimally inflated with viscoelastic or with fluid, and so that you have a nice and tight anterior chamber. Not over tight again. If it is over tight, then of course it becomes difficult, and trypan blue can at times help in aiding the position of the ports. Thank you very much.
Thank you, Partha. Very useful tips. When polishing the posterior capsule, I also employ one small aspect, that is of hydro polishing. Just before putting the intraocular lens inside, I always have a stream of fluid on the posterior capsule. Whatever small fibers, of course, if it's a plaque or something, it's not going to come off with that. And if I'm going to use an aspiration cannula, then usually I catch it. Actually, you get a spider web, and that also frees it up sometimes in a very controlled manner. Any brief comment? Yeah.
I'd like to comment on, femtosecond incisions. I think there are 2-3 important tips which can be given to our beginners. You have to make a incision visible by either drying with cellulose sponge or a little more magnification. Recently, what I do, I put a few drops of trypan blue dye over the incision area, and that highlights the incision. And first, you have to open the vertical incision, because these are normally biplanar or triplanar incisions. To open the vertical, then go straight, and that makes the life simpler. So it is the visibility which is more important in these cases.
But I think the incisions are the least important, and it doesn't really help to struggle, because there's always a large arcus. And the problem is with the liquid optic interface that we use, the applanation is not tight. So what you are using is a Lensex. The applanation is tight, so the incisions come out better than in a liquid optic interface, because there are microsaccadic movements and the plane is not that. So basically, when you are looking at a corneal incision, you don't use a liquid optic interface. So that's the main problem. It's more tough to open it, and you don't achieve anything much by the side port. So I have.
So this presentation
So
was for you, sir.
I'll
This
just.
presentation was for you, actually.
Oh, wait. Okay, thank you. Okay, this presentation is for you, how you save time once you get more numbers, Martha. So, thank you very much. I'll just show you. This is something which is saving time and not struggling like Partha was struggling. So, this is simultaneous incision. So, what we do is we don't use the forceps that he was using. This is holding the blade, and that is what is used to stabilize. And when what we go in is just go in, the other side is just stabilizing. Don't go in fully, and then you go in, and then you go in, and that's about it. And then you can put the viscoelastic. So Partha, here it is to save time and simultaneous incisions. You have made both the side ports, and you have made the main port. So this is my tip number 1. Ram, any comments or anything? Sorry? Okay.
You made only one side port at a time?
I only do one. I'm a coaxial guy. So
Okay.
that's the problem. I use the side port on this thing, but I'll try to get next time how to make 3 together. Okay. So anyway, this is what Amar kind of described, which is the SFT for. So one of the main things for all SFTs that he is doing is that they have to be either pseudophakic or aphakic. So this was a case which came to us from a perspective of a traumatic mydriasis. You can see this is a traumatic mydriasis, young guy who had an injury. And how do you manage this? So what we managed was to take a lens which was a plate haptic lens. I would have preferred an ICL, but that's more expensive. But this is a plate haptic IOL that we did. So this is a very simple tip for any one of you who has this particular thing. You just put the plate haptic within if you can afford an ICL, that's fine. And then you go ahead and then do the SFT, and you place the plate haptic in that particular meridian so that it does not hurt the lens. The key idea here is how to protect the crystalline lens, because these are long needles that you have to pass, and this will obviously the control is not that good, and you can actually hurt the crystalline lens. So this is just the SFT that's happening, and once you have taken this out, before you actually tie it, that means you have actually anchored it, you take it out, then you don't tie it, but you can then take out the lens, which is easy to remove because these are foldable lenses, and you can you can take it out from the same incision with the hand over hand technique. So once you have done that, you go ahead and do the incision, the tying of the suture, and that's pretty much the surgical end that you have. So this is the technique that we have adopted for doing an SFT, where there is the lens is pretty much non-cataractous and it is pretty much in the eye. So that's my second tip. Anybody?
I think it's a very simple but a very effective tip. Obviously worried about the anterior capsule and having something protecting that, and then subsequently doing the excellent thought process.
Thank you. So this is just a small pupil. This is a tip we normally, when you have a small pupil and you really want to do a femto procedure, this is because I'm in Calcutta, so I am showing the Suven's Bhattacharjy's ring, but you have to do a ring. So either it's a Malugan ring or it's a Bhattacharjy. You can't do this with the 4 iris retractors, because there will be 4 incisions and then you have to go back and dock. So when you do this, you can go ahead and do everything. So the questions that arise, so this is the femto procedure. 75 to 80% of my procedures are done by femto. So therefore, I am just showing you this, that we can do it with a small pupil. The only question that arises is that what do you do with the energy settings on the femto? So the question is that if you keep viscoelastic within the eye, then that can dampen the energy that is going on the capsule. So you up the energy by at least 50% for the capsulotomy. Or the second thing is that you can do an aspiration of the viscoelastic and put one suture and then do this thing, but that has to be done under sterile precautions. So this is just to show you how you can handle a small pupil with femtolaser assisted cataract surgery. Anything?
I think I'll be only concerned about the sterility
Yeah.
reasons, in the sense that femto is obviously not a sterile
No, but
procedure.
you can do it under sterile precautions, a femto also.
Yeah,
Yeah.
otherwise it's doable.
Yeah. Okay.
Just one query, sir. I am just seeing the capsule laser device, because as you're opening the chamber or putting the next ring, would it be beneficial? Suppose we stain the capsule also at that time.
Yeah, you can. I have not used the capsule laser. You can even
No,
do a
in this
Zepto.
one. In femtosecond also. That once you are opening the anterior chamber, putting the device, we might stain the capsule also, and you'll have a better visibility on the table itself with the capsulotomy has done complete.
Oh, you mean of the femto when
Yes.
you're doing a capsulotomy? Okay, let's try it next time. Great, but you can stain it later, right? How does it matter?
Once you are putting the device, maybe you put a
नहीं तो
dye
उससे
also
क्या
there.
that won't help in taking up the laser better. मतलब basically you can put
That
the
may affect the laser passage.
That's why I'm thinking.
Yeah,
Once
it
you
might
have a
affect.
viscoelastic, other things, it might hinder the laser application also.
Okay, this is Abhay is here. He's described this as regards the hydration that you get when you're doing you have a PCR and you get you need to do a vitrectomy. So vitrectomy should not be done from the anterior port. So this is the technique that we have described for subluxated cataracts, specifically in femtolaser assisted cataracts. This is again you can see this is a vitreous which is there. Can you see this? So on the OCT image, there is a vitreous that is there, and you can see that there is a subluxation here, and you can see that the iris is coming back. The important thing for you is to get there is a the bubbles have to be matched with the posterior capsule that is there. And you can see that once we have this, the anterior it has become more globular, if you could see. So you have to again match that particular thing. The other thing is that the advantage that you have in the femto in the tip is that once you are going to make the capsulotomy central by putting an endocapsular ring, so you can manipulate the capsulotomy and do it for a custom center or do it on a scanned capsule. So that is the other advantage, because you can even in larger decentrations get a capsulotomy even if there is vitreous that is there. But what I am trying to show here is that you do a pars plana vitrectomy, which is mandatory first, because the pull that is there, if you can see there is a tag here, that is this was a traumatic cataract, and this is doing the limited pars plana vitrectomy, which is important for you to not hydrate the vitreous. And because we know that there is a subluxation, we are putting an endocapsular ring right from the beginning. So the advantages that we have, that we have decompressed the vitreous, we have put in the endocapsular ring, we have pre-chopped the nucleus, and we are able to get this entire thing pretty much managed. The infusion is still on. You don't take out your handpiece in case of any subluxation, so that the AC remains well formed. And this is a 3-piece lens that you will want to put, as Ram had shown in dialysis. So this would be a good approach for any subluxations that you have with vitreous coming into the AC. So this is the final thing. I think this is again a publication as regards the use, what we were talking about the UBM, and then I was talking about the OCT. So we have actually the images to show you the okay, so this is just images that you can see, pre-existing defect. Polar cataract, you can see. Now what we are seeing in this particular case is we are raising this whole thing, and you can see that this is a defect here. Can you see this defect? And you can see this is intra-op OCT. Again, you can see that there is a defect. You can take out everything. You have left behind the epinuclear cushion. There is no disturbance of the vitreous. It is only when you take out the epinuclear cushion, you will see that this the OCT is giving Titial has fantastic images. You can see this is a vitreous blob that is coming, which is there, and you can go ahead and complete this particular procedure. I also had an image, sorry, it's not here, but the IOL Master 700 gave you the same image as you could get on the OCT on the Catalyst system, that there was a pre-existing defect. So imaging is very important for you to see and prepare yourself for posterior polar cataract. So that's another tip that I'll wish to say, give you, and I think these are a couple of tips that I I wanted to give you, and I thank Dr. Ramamurthy for giving me the opportunity to be here.
Dr.
Thank you.
Mahipal, just a quick question while Dr. Titial is getting ready. While, if you image and find that in a PPC, the posterior capsule is intact, do you think we can go ahead and do a conventional hydrodissection? All
Yes.
said and done, we do hydrodelamination, but it makes the entire procedure a little messy.
You are absolutely right. 99% of the times, I think there has been only one case of our series where we were misguided by what we felt that it was an intact posterior capsule or not. I tell my anesthetist no need of any peribulbar block because I don't think there's a rent, and we have invariably been found to be right. So if we are pretty much right on this particular thing that there is no defect that I have seen, it will turn out to be not having a defect on the table. So you can proceed as normal if that was your question, that answers your question. Yeah.
Now, I would, if you think clinically it's a posterior polar cataract and imaging shows posterior capsule, I would caution you. I'm sure we all can do it, but treat it like a weak capsule, because hydrodissecting subcapsularly, even with that intact capsule and imaging, can be fragile. We never know it. And I've shown these pictures very well. When you do hydrodissection after putting the lens in a posterior polar cataract, that ruptured. Do you remember that?
Yeah.
So the posterior capsule, you never trust posterior polar. So be safe. Even if you think you can, just try as a posterior polar, and if you need to resort to subcapsular, if you cannot, do it.
Yeah, but normally, even though he asked a question, I thought it was slightly, it's more an academic question, because in femto, you don't need hydrodissection or this thing, because there is pneumodissection that has happened and you can easily take out the nuclear fragments.
We have saved the best for the last. Over to Dr. Titial, teacher, surgeon, administrator par excellence. Over to you.
Thank you very much. I think I would like to show some of surgical intraop difficulties which we create and makes things difficult. And this is one case. I was operating, things are going quite appropriately correct. Emulsification is being completed here. And you can see I'm trying to aspirate the cortex here. The cortex is being aspirated. Just see what is happening here. So this is what has happened here. The entire bag has come out. So this is a time where we have to think what has happened here. Though PC is intact, I'm injecting the dispersive viscoelastic from the other hand and using the tamponade effect of a dispersive viscoelastic, then doing an aspiration bimanually now to complete that aspiration. The only thing what we have learned here is to identify the bag dialysis happening, because your hold has been little challenging here. I was holding both capsule as well as the cortex also while pulling. So this is how the rescue measure here. Dispersive viscoelastic was helpful. Bimanual aspiration did a wonderful job for this. Then subsequently placing CTR and IOL implantation. I'll go to the next case, which is also similar case here. I'm doing a aspiration of cortex here, done the complete aspiration. And I thought everything is complete now, injecting the IOL. So you do have a little fibers here. As we discussed, Dr. Ram was talking about cleaning of a posterior capsule. Sometimes I use my, optics of the IOL to take out the, these fibers. And this time when I'm doing this, the entire bag got dialyzed at this stage also. You can see the bag dialysis happening here. So you can produce these little changes, and sometimes it can be difficult if you are dialyzing a little bigger. So this is, again, I'm not leaving that like that. I'm putting a CTR underneath the IOL to maintain the bag distension in a uniform manner and getting the IOL to remain well centered in the bag also. So these two difficulties I did face before I shift to next case. Any comments from the panel?
I think something like this, Dr. Abhay also showed.
Okay.
Just a small tip. I mean, anything you do for removing epinucleus with your phaco probe itself?
So there, I think your phaco parameters should be under your control, and your foot pedal is the main concern. Make sure if your fibers are visible, and initially you should make sure your hydro dissection was proper. If your hydro dissection is good, you can do easily this process. If your hydro dissection is poor, then never attempt this because it will be difficult to pull those fibers. So it is when you are confident, you are comfortable, then do it. Otherwise, leave it. Okay, let me go to the next case, which is a person with high myopia with nuclear cataract. I thought I can do a routine surgery here. I stent the capsule, around 5 millimeter capsular access being done, good hydro procedure, and things are looking quite all right. Nucleus could be rotated. I'm doing a routine. It is around grade 4 plus phaco. Initial chop was done effectively, rotation happening, and another chop is being done here. So multiple chops normally I prefer in these cases. Now see that when I'm trying to take out, the entire bag is loose and moving. And this is a stage where I got worried. So let me put this question to Dr. Ram. What would be your approach at this stage when the entire bag is loose?
I would maybe put an endocapsular ring in place right now, and then secondly, create that. I don't think your nucleus fragments are completely separated. So I'd go ahead and create a deep trench, and maybe go with 2 Sinskey hooks and separate them into 2 heavy nuclei, and then very gently remove them.
Capsular hooks. Capsular hook on the capsule.
Okay.
Only capsular hooks or endocapsular.
I think first step would be capsular hooks. That itself will stabilize the bag. Then you can plan about the CTR.
So I agree to Dr. Chitra here because I have to agree with her only. So I'm doing the same. Once your bag is totally loose and it is, your nucleus is not being rotated, so both can be there. You can put CTR as well, and you put capsular hooks. Both can be put at this stage also. I prefer to put hooks there to stabilize the capsular bag, and normally around 4 or 5 hooks because this is an entire loose bag. Just putting 2 hooks may not suffice. So I have a stronger hold here and stronger. These are 2 axes where you're going to have more this thing. And Dr. Ram was suggesting I'm trying to separate the central piece here. Now I could separate the central area. Now I can take out the pieces very effectively also. So I could complete the phaco effectively subsequently. I'll just go a little faster and aspirate the cortex with a bimanual aspiration. And make sure your bag remains, this is a loose bag, so you can damage the posterior capsule also. And there, maintenance of anterior chamber is very, very effectively should be done. Always where a loose bag is there, bimanual aspiration really is a good help in these cases also. So at this stage, I thought, what should I do? This is a high myopic patient, as such required the expand range of IOL. So what will be your idea, Dr. Abhay, to implant the lens? Should I implant the lens in the bag, or what should I do? Dr. Chitra. Mic.
First, you should put a CTR at this point of time.
Okay.
It is a loose bag.
Yeah.
So then only you can remove your hooks.
Yeah.
So after you place your CTR, then you can loosen your hooks, and then you could place your lens.
Okay.
And if after that you feel that the lens is better off not in the bag and your axis is smaller, then you can even do a reverse optic capture.
So I didn't put a CTR in this particular case. I'm putting lens in the sulcus. Haptics will remain and getting the optic capture done in the anterior capsule for stability. CTR should have been one option here that I missed in this patient. Good option. So I'm trying to rotate the haptic into the sulcus and trying to get, because this is a very, very loose bag, the entire lens was moving. Then I get to the capture into anterior axis. So these are 2 combination, haptic in the sulcus and optic capture in anterior capsule in a high myopic patient. Subsequently, I put a suture and completed this surgery. Yes, Abhay, you wanted to make comment?
That's what I was going to tell you. But I sometimes I'm tempted to do capture also, because this is a loose bag, and you're depending on this loose platform. Even if your haptics in the sulcus is not going to, IOL won't be shifted because they are fixated in this thing. So if you doubt if the capture is not that good, you need a decent capture, anti-capture. If it's not there,
BCCC also.
Yeah, I think that would have been a better idea to capture both anterior posterior wise. Thank you, Abhay, for nice comments, and thank you, Dr. Ram, for giving me this opportunity to be with you. Thank you.
Thank you so much. I think wonderful team effort, and thanks all the panelists, and thank you all so much for joining us so late in the evening. Thank you.